So I just want to talk a little bit about pulse oximetry, and this was actually based on a presentation that I created, online presentation for Nocor, and they paid me, but they never used it, so I don't know what that means. So here are the objectives, and again, it's always perceived as being a valuable measurement. It's the continuous non-invasive assessment of arterial oxygen saturation. We use it more often as a spot check, but was really designed as a continuous, and it helps prevent hypoxia as being just differentiating between arterial blood analysis and pulse oximetry. And you can see non-invasive versus invasive, real-time data on a continuous basis rather than just a snapshot. And there's always some delay with ABG. With pulse oximetry, it's right there. So here I have a patient that's in the respiratory distress, septic shock, poor peripheral circulation. You can see them on dialysis. Pulse oximeter reading is 80, arterial saturation is 94 with a PaO2 of 78. And the question is why? They actually looked at physicians, therapists, and nurses, and it's kind of embarrassing to see some of the results there. Pulse oximetry is not an indicator of adequacy of ventilation. 44% of the nurses thought it was. And these are critical care nurses. So it's like, which is even sadder, 7% of the therapists thought it was that. So kind of on the scary side. Some other studies looking at knowledge gap. About 20% of PACU nurses thought that SpO2 and PaO2 were the same thing. 89% thought a pulse oximeter was accurate to within 1% of the actual saturation, which it certainly is not. Good majority thought that the normal value in an adult is somewhere between 93 and 100, which it's not. 37% thought that the finger sensor could be used in the same extremity as a blood pressure cuff. Hello, McFly. You're cutting off blood flow. There's no pulse. It's going to give you an alarm, or it should give you an alarm. So again, what you're using with a pulse oximetry is you're shining two light sources, one infrared, one visible light, through a vascular bed, detecting the signal on the opposite side. We know that the signal can either be absorbed, reflected, or transmitted through. If it's a wavelength of light specific for oxyhemoglobin, it's going to be absorbed within it's going to be absorbed by the oxyhemoglobin within the vascular bed prior to seeing the photodetector, and that's basically how pulse oximetry works. We know that there's a lot of artifact, and we're using two components, the photospectrometric method to be able to discern which wavelength of light we're looking at. So the one specific for SpO2 is different from the one for reduced hemoglobin. And we're using the plethysmography component to identify at what point we want to do this measurement. And obviously we want to do it at peak systole when the pulsatil flow is the greatest, because that's going to give us the biggest change in oxygenation that is there. All the other stuff that is there can lead to, is basically artifact that you end up having. And again, the sensors are designed, the typical one we use is the one on top, the transmission sensor, where LEDs are emitting light and detecting the opposite side. There is technology that is a reflectance sensor, and I'll show you some examples of those and what some problems that can exist. Most specifications are one standard deviation as far as ±2 for adults, or ±3, with a range of 70 to 100%. Statistically, that means that at a saturation of 94, it could be anywhere between 90 and 98. So it's not as precise as sometimes I think we think it is. Statistically, that two standard deviations would be about Yeah, 67% will be within 2%. So it's basically what we say is 2 to 3% plus or minus is what you're looking at. And most hospitals consider pulse oximetry levels above 92 is safe. That's the way it's usually written up. We know that as far as transport is concerned, that dissolved in the bloodstream is very minimal compared to what is attached to the hemoglobin. And that assumes that we have functional hemoglobin in the process. We don't have dysfunctional like carboxy and met. And in those cases, your pulse oximeter is going to read a normal value. So you've got to bear that in mind. We know about the shift of the oxyhemoglobin curve ad nauseum. We know what will end up causing that to happen. Leftward shift, rightward shift. That's a horrible slide, but you know it. How about this one? Yep, I kind of figured that was the case. Come on. And you all did very well. Proud of you. Because you got basically looking at that which is dissolved to or attached to hemoglobin, which you can have, 100% saturation, but only have 7 grams of hemoglobin present. Working the ER, treating a patient with abdominal pain and suspected aortic aneurysm. You can see some of the readings there. He's not on oxygen and has a 96% saturation, but he complains of lightheadedness and being confused. What do you think could be a possible cause? It could be that he has a reduction in oxygen delivery because his hemoglobin level is low. Somebody suspected of an aortic aneurysm could potentially begin the process of bleeding out. We have handheld, we have standalone bedside monitors, we have them built into vital signs monitors, and they're even available as a mobile multi-parameter monitor. You got to take into account which patient we're using this on based upon body size, based upon the activity level, and how long we'll be monitoring. There's also concerns related to infection control, skin integrity in the case of neonatal, and peripheral sensor. Basically, based upon a patient's weight, we should have a good fit. That means that the alignment of the photodetector and light emitters, light emitting diodes have to be balanced across from each other. Active patients are probably going to be done better with a single patient use sensor because the multi-use sensors have more of a tendency to fall off, if nothing else. That second skin fit refers to like the Band-Aid that you end up having. You can get a far better sensor placement for long-term monitoring. They are typically packaged sterile. They can be reused. Where a reusable sensor you have to clean. And just incorrectly placing the sensor will give you some false readings. Just remember also about a PDA in the case of a neonatal patient. So some tips. Try not to use it with an arterial catheter, blood pressure cuff, or an intravascular infusion line. Try to use the alternative arm or hand. It should not be placed so that it's constricting. If you've ever put a Band-Aid on too tight, you felt that pulsatile flow. That's actually a venous pulse that you end up feeling. That's going to be interpreted as an arterial reading and can be a reason why your saturation is lower than it actually is. It's designed to be placed at a specific site. Here is an example of a sensor that is the one on the right-hand, actually has two of them on. The one on the right-hand side is designed to be a reflectance sensor using the skull as an idea. And you can see it's a very good correlation both with a CO oximeter and on, This is the one that's placed on her ear. You can see the correlation's pretty good, not quite as good as they have a reflectance sensor. This is the one I want you to remember, okay? Have you ever seen this done in the ICU, where they take a sensor designed for a finger and they place it to the incorrect site? Here's the problem with the reading. Not only are you off, you're off in the wrong direction. You overestimate the actual saturation. So you got a better number than you really have. Okay. I've walked into ICUs and I told nurses, you can't do that. Well, I got a number, but it's wrong, and you don't know how wrong it is. It could be a little bit wrong. It could be a whole lot wrong. I mean, if I'm doing this when the saturation is really that black line, we got some problems. Here I have my sensor designed for a digit on the forehead. Look at that sat. Here's where the reference was on the digit as this patient was desatting. And this is done in a lab. This isn't done on, obviously, we don't want our patients to probably have an 80% saturation and lower. But when they do the testing, they actually have the patient breathing 17% oxygen, and they watch them desat. How'd you like that job? The reason why these reflectance sensors work so well and have such a great quick response is they're feeding right off of the supraorbital artery, which is a direct branch off the internal carotid. If it's placed just above the eyebrow, you can end up getting one, perfusion is not as badly affected as it would be in other peripheral sites, and they actually can monitor response time very, very quickly. As far as the skin-related trauma, we know about this in newborns. We kind of forget about it sometimes in the elderly. So just moving the site frequently, using non-adhesive sensors. There's a lot of wraps that are available that are Velcro-based that can hold a sensor in place without using adhesives. We know about the ductus arteriosus being postductal. Or I'm sorry, anything measured on the left side is being postductal. So one of the things you can do is place it on the right hand and the right foot, or left foot, and you'll see a difference in saturations when you have that PDA open. Common conditions that can cause problems: light interference, any other light other than what is there will allow for an error in reading because it could be picked up on the photo detector. Edema was there because typically with edematous tissue, the sensor doesn't fit really well as having the two LED and the photo detector opposite each other. You can see this edema, the poor swollen leg there and foot. This is just looking at the level of hemoglobin. Again, you need to have a decent amount, but anemia will end up having problems. Skin pigmentation is a lot huger than it is. Because the skin is pigmented, it will absorb some of the light, so you won't see it pass through. So you'll get a saturation that is, because it's being absorbed, you're thinking the saturation's higher than it actually is. And there's been cases where nurse thought the saturation was just fine when it really wasn't, just simply because of the pigmentation involved. Nail polish, especially brown, blue, or green. Intravascular dyes, we don't really worry that much in the ICU. Somebody comes in with CHF, she's monitored with pulse oximetry. O2 on 3 liters is 92% with a pulse ox alarming periodically. And we basically can end up needing to place that perhaps at a different site. We're not seeing good response. Some improvements that we've made as time has gone on. Earlier, the first portion of using pulse oximeter, we're using the OR, We had stable, relatively motionless, well-perfused patients. As we got outside into the general care floor, you end up with all kind of other problems, and that's where the new generation pulse oximetry has tried to improve it. Yeah, all new generation pulse oximeters, regardless of manufacturer, work better than the older generations ones. So you're seeing fewer false alarms in the presence of reduced blood flow from low pulsatile signals, as well as through patient motion, because that motion will give you difficulty in finding where the arterial signal is. 32-week gestation baby, periods of quiet breathing with bouts of restlessness, pulse oximeter reading during this restlessness. During when she's moving, you get a lot of alarms, and again, that's simply because of that inability to read through motion, and the increased motion obscures the signal. So using the newer technology makes sense. And like anything else, the algorithms have gotten better and better as time has gone on. So we're able to not only read through the motion, read through the artifact, but get a faster response in the process. And the calibration curves have improved with that also. Some other problems with nuisance alarms, and this is one of the, I was just talking to somebody about JCHO inspection. They were saying that alarm management of nuisance alarms are one of the things they're trying to hone in on to find out how the hospital is responding. Not only do we have situations where the alarms are turned off, there's been cases of a baby found, well, no, it was a child actually, a small child, I think it was a 3-year-old. Pulse oximeter sensor was on, pulse oximeter was turned on, pulse oximeter was alarming, but the alarms were turned off, they were silenced. So never picked up on the fact. And alarms being tuned out. How many different alarm tones do you hear in an ICU? Oh my God. It's very easy to just tune them out in the process. Newborn, multiple monitors, staff response to the alarms, ignore them. Why would you have an audible alarm if you're just going to ignore them? It kind of makes... So it's a fact or artifact that we're looking at. And again, a lot of it has to do with improving the technology involved. I can't even read that. Neither can you. Let me read this. Can you guys see it on yours? Yeah. Okay. Monitoring of patients during post-op period where hypoxemic is the greatest. There was a study in Copenhagen. 6 of 22 adult patients had episodes of hypoxemia associated with tachycardia. And these were just 22 consecutive patients post-operatively that they placed on a pulse oximeter just to kind of see what was going on. 4 of those 22 had episodes of hypoxemia with myocardial ischemia, FT segment changes. 3 of the 22 had episodes of hypoxemia associated with a heart block. So these are patients that we purposely were just, ordinarily I might not monitor them, but let's go ahead and monitor them post-operatively. Every episode occurred in sleeping patients. So whenever unfortunately patients do have to sleep. That's when we hypoventilate the most. That's when we desaturate the most. So one of the arguments is to do some sort of remote monitoring. There are hospitals that basically have established, just like you have telemetry monitoring of EKG, doing telemetry pulse oximetry. And this is an example of where you can have a radio transmitter going back to a centralized station. The centralized station not only tracks trends, it'll also obviously pick up on the alarm, and they're actually set up so that when an alarm goes off, it can go to your beeper. Oh, yeah. That remote oxygen system allows the movement of patients out of the ICU to a step down or a floor, because we know that bounce back problem usually involves a higher cost per the admission and also is associated with a higher mortality. So when we transfer somebody out of the unit, we want to keep them out of the unit in the process. This is interesting, and this I guess I kind of never knew. I always thought that, you know, the oxygen saturation that's in one artery is the same oxygen saturation throughout any artery, and it's really not the case. The peripheral actually may lag behind a change for as much as 2 minutes. So that peripheral may lead you to some problems in patients, especially if they're hypoperfused in some process. And that's one of the arguments for using that reflectance sensor on the forehead. Here's an example of what this is talking about. So they basically made the room cold. They dropped the temperature within the room. They placed the patient on low oxygen so that they would desat. And you can see that this black line is looking at both the radial artery, so sampling from a radial artery, and this forehead sensor. And you can see there's a delay from what we're reading in the finger and a definite delay from what we're reading in the ear. So where the sensor is placed and the technology used in that sensor make a difference as time goes on. So yeah, they got this patient down to an FiO2 at 10%. Not a patient. They had his volunteer, and they paid him $20 and sent him home. You know. So during and again, this is cold where we're dealing with vasoconstriction. There can be as much as a 3-minute delay from what you're seeing on a forehead versus what you're seeing in a finger. Pretty significant differences. Red is the warm room. You can see it's a little bit higher than the cold room. Again, cold, that vasoconstriction is going to have a little bit of a problem. Is getting a good signal. This is looking at pulse amplitude. And again, this is talking about, again, hypothermia, the regulatory control of blood vessels. And peripherally, when you're cold, you tend to shut down, and that's why you end up losing a lot of the signal. And that's the argument for going to that kind of a process. So here was our signal, where we went back to our patient who was hypotensive, and basically looking for some alternative placement of the sensor is the idea. And I'll leave it at that. Okay? One question on